Assalamu alaikum and good morning to everybody. I would like to thank the organizing committee and particularly to the president of Saudi Heart Failure Group, to my friend and to everybody for inviting me again to this elegant meeting. I feel privileged to be part of this elegant meeting. I am supposed to speak about in the first session, to speak about the optimization of the use of biomarkers in acutely decompensated heart failure. You see below are my disclosures in the meantime. The term biomarker was first introduced in 1989 and was defined as measurable and quantifiable biological parameter which is used to assess health and physiology in a patient in terms of disease risk and diagnosis. And this definition was later amended in 2001 by NIH Working Group as an objectively measured parameter that is an indicator of normal biological processes, pathogenic processes, or as a response to pharmacological therapy. So by this definition of biomarker, actually everything we measure, we look at during our hospital visits, during our visits, official visits, is actually a biomarker. So ECG is actually a biomarker. But by saying a biomarker, we usually mean something we measure in blood or urine from a practical purposes. But for an ideal biomarker, we need an idealization of a biomarker in heart failure. An ideal biomarker is supposed to be highly sensitive and specific and should reflect abnormal physiology and biochemistry, and moreover, they must be cost-effective and have a low coefficient of variation and must be usable across diverse groups. And if honestly speaking, we couldn't find that biomarker so far yet. But multi-marker paradigm in diagnosis and treatment of acute heart failure must be considered according to Moore and co-workers published a well-cited journal in circulation in 2007. And we should keep in mind that heart failure specialists are actually seeking hemoglobin A1C of diabetes mellitus, and we couldn't still find it, maybe because of some technical problems as well. But we all know that patients with cardiovascular disease, not only heart failure, generally have a relatively poor prognosis, so it is critical for us to have simple markers to predict something's short, medium-term outcomes in order to optimization of our treatment management strategies. And prognostic evaluation has successfully been developed and applied in cardiology, particularly for coronary artery disease. We all know the troponin story and the myocardial infarction. And patient management for this syndrome is often invasive, sometimes involves relatively aggressive therapeutic procedures such as circulatory support, cardiac transplantation. So it is critical to validate prognostic markers at the patient's admission during the first few days of hospitalization or at discharge in order to select best therapeutic option. And we all know that along with the myocardial injury and the decreased LV function and along with the neuroendocrine activation, and also just by the increased venous pressure, we end up with cardiac remodeling biomarkers, myocardial stretch biomarkers, increased renal interstitial pressure biomarkers. So we have a huge list of biomarkers, and everybody's trying to catch up one part of the elephant story. And why do I need biomarkers in acutely decompensated heart failure? At least I can count 4 reasons for them. For diagnosis, of course, first of all, and it is relatively well-established story. I need them during triage at admission because I have to triage my patients according to disease severity. And I may also need them during the in-hospital journey of these patients because I have to do, again, the triaging during the in-hospital journey and also management strategies. And also I may need them for prognostic purposes, both short-term and long-term. And according to a very recent publication led by the Professor Alan Cohen-Solal, who was one of the guideline writers of 2008, actually, from the Paris group, they have made kind of a meta-analysis and investigated the biomarkers which are proven to have a role in the heart failure story, and they categorized the biomarkers into 3 subgroups. Those related with the in-hospital mortality, medium-term mortality, and the heart failure rehospitalization. And as you all know, heart failure rehospitalization story is quite important in the American continent. Let me begin with the natriuretic peptides. They are quite well-famous semi-quantitative markers of heart failure story. And NP testing constitutes standard of care for patients with heart failure as illustrated by recently published guidelines, but the use of NPs in clinical practice varies according to the clinical scenario. I always mention in Turkey, still NP is more expensive than echocardiography. In acute heart failure, on the other hand, their usefulness is a bit questionable, but the delay in obtaining the results may affect the management strategy and the outcome of these patients, and therefore limit their benefits. So just timely acquirement of these NP biomarkers is critical. And as you all know from the ESC guidelines of 2012, which is not going to change, by the way, because I am one of the reviewers of the upcoming 2016 guidelines, in patients with the acute onset and the suspected heart failure story, we need biomarker story. And if the ECG is normal and the NT-proBNP is less than 300 picogram per ml and the BNP is less than 100 picogram per ml, heart failure is quite unlikely. These limits, these thresholds are just being utilized for the exclusion purposes in the emergency setting, because we need to exclude the presence or absence of acute heart failure, actually the presence of acute heart failure immediately in the acute heart failure setting, because time is muscle, just like the acute myocardial infarction story, according to the RELAX-HF study, just according to the most recent data set. But on the other hand, for example, just mention about the NT-proBNP cut points. I would like to mention about mainly NT-proBNP, because you all know, because of the LCZ696 story, the BNP could potentially be out of the story at least after the diagnosis or the initiation of the new drug. So I would like to put my emphasis on NT-proBNP, which is kind of a more available biomarker nowadays. And we actually rule in cutoffs or thresholds according to age strata with regard to NT-proBNP. And as you see, if your patient is less than 50 years of age, the optimal cut point looks like 450 picograms per ml with a quite acceptable specificity. And high specificity means rule in. But on the other hand, optimal rule out cutoff point is only one level. It is 300 picograms per ml, and as you see, the sensitivity is very, very high. So you can definitely and clearly and very easily exclude the presence of acute heart failure. But for ruling, you need different thresholds levels. So you have to check from the paper of the biochemists when you have it. But on the other hand, excuse me for that. There are several causes of elevated natriuretic peptide levels, including cardiac reasons, heart failure, RV syndromes, acute coronary syndromes, even atrial fibrillation, myocarditis, cardiac surgery, even cardioversion. And on the other hand, there are several non-cardiac reasons of elevated natriuretic peptide levels: advancing age, anemia, renal failure, bacterial sepsis, critical illness, severe burns. So we have to keep everything in mind during the differential diagnosis of acute heart failure. What about in-hospital journey and NP? Several studies thus far have documented a significant correlation of both BNP and NT-proBNP with the left ventricular filling pressures. Just for example, one author demonstrated in considerable amount of patients presenting with heart failure that the BNP levels strongly correlated with the left ventricular and diastolic wall strain. So you see the R level is 0.887 with a very significant P level. This is very high level of correlation. And also the correlation is significant with regard to end diastolic pressures. So just diastolic filling patterns determined by the echocardiography have a very good level of correlation with regard to BNP levels as well. And although BNP and NT-proBNP cannot distinguish between diastolic versus systolic heart failure, studies also shown that NPs correlate with the diastolic wall stress and also dysfunction as well. So they can be utilized to measure, to evaluate the level of diastolic wall stress in patients with heart failure with preserved ejection fraction as well, as in quite a semi-quantitative manner. And what about, again, in-hospital journey? We all know that BNP concentrations less than 300 to 400 picograms per ml at discharge are predictive of better outcome than higher values. And not only the absolute NP concentration at discharge, but also decrease in NP concentration between admission and discharge is also prognostic value, as shown by Lojard et al., Betancourt et al., or Cohen-Solal et al. An insufficient decrease in the BNP or NT-proBNP in response to treatment is associated with a poorer outcome, just as shown by the Betancourt paper. He and co-workers evaluated the serial testing in patients with acutely decompensated heart failure, and they clearly demonstrated that in the study, 30% increase or 30% decreased levels of NT-proBNP demonstrated a very, very good risk prediction. So if you decrease the NT-proBNP more than or equal to 30%, you end up with good outcome. If you see a 30% increase in the NT-proBNP, you end up with the bad outcome in patients with acutely decompensated heart failure. And also just composite event rates was higher in patients with a percentage reduction in NT-proBNP less than 30% compared to those with more than 30%. So it is quite correlated with the outcome, good short to medium term outcome of these patients. But in the in-hospital journey and the NP story, we have to take care of a lot of things into account. For example, intensive care management, fluid management, mechanical ventilation, hemodialysis, cardiac dysfunction, renal dysfunction, diuretic use, biological variations, and other factors all contribute to the levels of circulating NPs. And I'm not now speaking about the metabolism of these molecules, but it is quite confusing. So that is the reason I'm always using semi-quantitative markers of heart failure story. These are. And despite these facts, the 2014 Canadian Cardiovascular Society Heart Failure Guidelines states that during the hospitalized setting in patients with acutely decompensated heart failure and before the discharge, more than 30% decrease from the admission value. These patients can be discharged if relatively free from congestion. And in patients with stable ambulatory heart failure, 30%, more than 30% increase from the baseline clinical value means you need to do more frequent follow-up. So just they recommend the change of the natriuretic peptide levels during the hospital course of these patients. By saying during the hospital course, I mean, of course, the admission levels and any level before the discharge, but not strictly. What about other markers? Mid-regional pro-ANP is more likely to reflect left atrial overload in the meantime, and we all know from the Bach study that the levels of mid-regional pro-ANP with a threshold of 120 picogram per ml can be quite equal to BNP and NT-proBNP, but the elevated concentrations of mid-regional pro-ANP probably associated with longer history of heart failure as an increase in the size of the left atrium reflects the chronicity of the left ventricle failure. So just, although currently it is primarily restricted to uncertain BNP levels, prognostication in combination with other peptides, mid-regional pro-ANP can have a role in relation with the left atrium in near future. What about prognostic assessment? We all know that prognostic scores measured at patient discharge, including the biomarkers, have a better prognostic value than those determined at admission. So just, it is quite advisable by many guidelines to measure the biomarker before the discharge of these patients. But we should keep in mind that the long-term prognosis of the patients, even the medium term of the prognosis of the patients, are affected by many things we do, including coronary angiography, revascularization, resynchronization, ICD therapy, rehabilitation, blah, blah, blah. So just several things are influencing the mid to long-term outcome of these patients. So only biomarker cannot do anything alone. What about other biomarkers? Procalcitonin release is induced by bacterial endotoxin, making procalcitonin is an effective marker of ongoing bacterial infection. It is studied by Alan Maisel and co-workers, and he demonstrated that procalcitonin was useful in identifying patients with acute heart failure and a significant cause of acute heart failure, namely pneumonia, underlying pneumonia. And study evaluated the patients with acute heart failure who presented to the ED and identified those with pneumonia and those receiving antibiotic use, following which procalcitonin levels were measured in these individuals using sensitive assays. And they shown that median procalcitonin concentrations in patients with pneumonia were 0.18 and versus 0.07 picograms per ml for those without pneumonia. So using procalcitonin levels improved diagnostic accuracy and the physical estimates diagnosing pneumonia in patients with acute heart failure. And the study also suggested that if the procalcitonin levels is more than 0.21 picograms per ml, excuse me, it's nanograms per ml, excuse me for the levels. Antibiotic use improved survival in these patients, suggesting the possibility of procalcitonin-guided antibiotic use or avoiding unnecessary use of antibiotics in patients with acutely decompensated heart failure. Some authors, particularly those living in the USA, are recommending utilization of procalcitonin in decision-making tree of the pneumonia, in addition of pneumonia to the story of acutely decompensated heart failure. What about troponin troponins. Troponin T is a regulatory protein attached to tropomyosin in cardiac myocytes, released in response to myocardial infarction, namely secondary to coronary or non-coronary causes, including acute heart failure. It's a sensitive marker of myocardial injury. The levels correlated to the degree of myocardial necrosis with high sensitivity is now available, detecting even tiny, minute levels of troponins. It is, however, not a specific diagnostic marker, with high levels also possible in acute kidney injury, sepsis, subarachnoid hemorrhage, and amongst the others. So we have to be very cautious while recommending on the levels of troponins. What about copeptin? It is derived from pro-vasopressin, and copeptin is a carrier protein of serum vasopressin levels. AVP is well-known part of the story of the heart failure. As with other vasoactive hormones, AVP is rapidly degraded, but we now know that there are equimolar levels of copeptin, which is the N-terminal part of the AVP story. So just we can make some estimations by utilizations of the copeptins, but we all know that AVP antagonism is worth trying on it, although the Everest story was kind of a neutral study, but it was kind of from my point of view, it was a wrong study design. So just another study now, it's on its way, it's namely Activate, so the AVP story may come back again. And copeptin levels has shown to be useful in prognostications of patients with acute heart failure, both in short and long term, maybe complementary, may perform superiorly to NT-proBNP, but specifically elevated copeptin level, since it is the N-terminal part of the AVP, the pre-pro-AVP molecule, so equimolar is secreted with the AVP and the copeptins. So elevated levels may signify the short-term mortality and need for transplantations, particularly when combined with the presence of hyponatremia. So it is quite a good marker of the hyponatremia and the AVP story association, and its prognostic capacity holds independently of renal function, so it can be an important part of our management. ST2 is the following overload and mechanical strains. It's released from cardiomyocytes and fibroblasts. It's kind of a mechanical strain biomarker. It is also utilized in the Americas story a lot. And what should I do according to the guidelines? And the American guidelines state that in the story of biomarkers in patients with acute hospitalized patients, measurement of BNP and NT-proBNP is useful to support the clinical judgment for the diagnosis of acutely decompensated heart failure, especially in the setting of uncertainty for the diagnosis. So if a patient comes with a lot of complaints, and if we have a problem in the differential diagnosis, we need them. Measurement of BNP, NT-proBNP, and/or cardiac troponin is useful in establishing prognosis or disease severity in acutely decompensated heart failure. More elevated BNP and the troponin levels means you have a more severe disease and the patient is more likely to die. The usefulness of guided therapy for ADHF is not well established, so we still some more time with regard to the guiding our therapy. And other biomarkers of myocardial injury or fibrosis may be considered for additive risk stratification in patients with acutely decompensated heart failure, according to American guidelines. And just when we look at overall the recommendations for biomarkers in heart failure for diagnosis or exclusion of heart failure, prognosis of heart failure, to achieve guideline-direct medical therapy and guidance of acutely decompensated heart failure therapy. They have different levels of indications, but we should keep in mind that for guidance of acutely decompensated heart failure therapy, it is still 2B indication, so it is quite low indication. But by saying guidance of acutely decompensated heart failure therapy, I do not mean that admission and discharge levels, because we need to the differing levels, decreasing or increasing levels are important for prognostication of these patients. And just other biomarkers of myocardial fibrosis can have additive role in the risk stratifications of these patients. And I would like to mention about the last, but not the least, the recommendations paper recently published in the European Heart Journal, and they recommend laboratory tests at presentation and also monitoring in the hospital. And upon the presentation to ED or CCU or ICU, depending on the severity of the disease, and BNP, NT-proBNP, or mid-regional pro-ANP should be measured in all patients with acute dyspnea and suspected acute heart failure, ideally using a point-of-care assay, some of them are still lacking, to help in differentiation of acute heart failure from non-cardiac causes of acute dyspnea. And also, these recommendations papers also recommend that the troponin BUN these are also biomarkers, creatinine, electrolytes, glucose, and complete blood count in all patients with acute heart failure. And during the monitoring stage, meaning in-hospital journey of these patients, renal functions and electrolytes should be measured daily, and plus, and pre-discharge measurement of natriuretic peptides is useful in these patients, so we should consider pre-discharge measurement of natriuretic peptide levels in these patients as well. This is all I would like to speak about. Thank you for your attention.
Thank you.
It's finished.